Thank you so much, Hope, for that introduction. And thank you to everybody who's joining us here this afternoon. It's my privilege to speak on behalf of the Lymphoma Research Foundation about relapsed and refractory chronic lymphocytic leukemia and small lymphocytic lymphoma or leukemia, also known as CLL and SLL. There will be an opportunity for questions, as Hope mentioned, and I look forward to speaking with everyone at the end of the talk. So first things first, kind of going over a history of the treatments of CLL, going all the way back into the 1950s when we first started treating this disease using steroids and chemotherapy. If you look down this timeline, kind of as recently as into the 2000s and the 2010s, there's been a multitude of new kind of treatment agents that are coming onto the landscape for CLL treatments. And it's really a very exciting time to be in this field because we have so much research kind of moving forward and finding new treatments for patients every day. And so this timeline basically shows that as a field, we moved away from chemotherapy treatments and more into this era of what are called targeted treatments, starting around in the early kind of 2010s with the first FDA approval of ibrutinib back in 2013. And we've been kind of moving in that direction ever since. So we're going to be talking a lot about different targeted therapies. And so I wanted to make sure that early on I introduced all of the different players that we have in the relapsed space and that we use to treat patients with in the clinic. So different categories of targeted therapies. The biggest category right now is Bruton's tyrosine kinase inhibitors or BTK inhibitors. And you'll see it kind of the acronym BTKI throughout the talk whenever I'm referring to those. Currently FDA approved are ibrutinib and acalabrutinib, and zanubrutinib is the latest one, which we're expecting FDA approval any day now. Another category of drugs is BCL2 inhibitors. Really the only drug in this category right now is Venetoclax, but certainly more kind of in the pipeline. We also have monoclonal antibodies, and people may be familiar with those, even not in the context of CLL, but we've actually used these to treat COVID-19 pneumonia as well. And so certainly there's many different applications of these monoclonal antibodies. The ones that we use in CLL most commonly are rituximab, Venetoclax, and occasionally ofatumumab. And then lastly, we have a category of targeted drugs called PI3K inhibitors, which target a specific protein called PI3K, and two are currently approved for CLL, idelalisib and duvelisib. So these are going to be our key drugs that we talk about throughout the remainder of this talk. So targeted agents are really preferred for most people with CLL, but how we actually sequence all of these drugs together remains somewhat an area of active investigation, and really a lot of it depends on many different factors, which we'll go through later in the talk. So just to briefly introduce, for patients who are first diagnosed with CLL and meet criteria for treatment, our National Comprehensive Cancer Network, or NCCN, currently recommends really a combination of 3 to 4 different options. As clinicians, we like to think of anybody who's coming to our clinic in certain categories to let us know the optimal path forward for those people. So here I've kind of divvied up those categories into 3 of the broadest categories that we consider as clinicians. In the first, we have people who are a little bit older, may have some medical problems, and may not kind of be what we call medically fit enough to take a very intensive therapy. For those people, we consider acalabrutinib, which is one of those BTK inhibitors, with or without a monoclonal antibody called Venetoclax, ibrutinib, which is a BTK inhibitor as well, or a Venetoclax strategy using that BCL2 inhibitor. For patients who, and I'm kind of jumping around a little bit, you'll see why on the very end of this spectrum, we have patients who have slightly higher risk disease. And so for those patients, we also consider those kind of three combinations that we discussed. It's really that column in the middle where we have young patients who are a little bit more maybe medically fit, who we sometimes still consider the possibility of what we call chemoimmunotherapy, which is a combination of traditional kind of chemotherapy regimens with or without a monoclonal antibody. Now, as we move forward as a field with more and more kind of targeted agents available to us in an FDA-approved setting outside of clinical trials, the role of chemotherapy in the treatment of CLL is really kind of going by the wayside. But I will say that occasionally I still have that patient who I just feel like might actually benefit from chemotherapy. So I just kind of introduced that as a caveat to be thorough. So again, this is kind of the first line, so somebody who's never seen treatment for CLL, but now kind of going into the remainder of our talk, which is focusing very much on relapsed patients or refractory patients, similar recommendations actually still exist. So you're still kind of dealing with all the same players, acalabrutinib, ibrutinib, both BTK inhibitors, and then Venetoclax with rituximab, which is another type of monoclonal antibody. Now, in addition to those three drugs, we also, in the relapse setting, layer on the possibility of using PI3K inhibitors, which, again, as we mentioned, are idelalisib, which is actually given in conjunction with a monoclonal antibody, rituximab, or duvelisib. And so those are going to be really the drugs that we focus on moving forward in this talk. And so the biggest question that we kind of face as clinicians is how to best sequence all these different drugs that we have available to us in the clinic. A lot of times the way that we actually end up sequencing these drugs or having them available is not really inherent to kind of tumor biology or the disease itself, but really it's just whatever research kind of hit the market first and which drugs got FDA approval first. And so, sometimes there's a disconnect between kind of what is best for treating the tumor versus kind of just what do we have available, based on timing, based on trials. So that's one thing to kind of keep in the back of our minds. But whenever we see somebody relapsing or progressing with CLL, we have to consider really three different groups of people. Group one are people who got ibrutinib or acalabrutinib in the front line, meaning their very first treatment of CLL. Another group is people who got Venetoclax first. And then another group is people who really never got any targeted therapy and instead they received chemotherapy. And that group three is shrinking and shrinking, becoming smaller and smaller. So really we're going to focus on that group one and group two. Now for everyone, regardless of whatever frontline therapy they received, we have to think about the reasons for why they had to discontinue their frontline therapy. Did they complete their therapy and then they had progression off of any kind of treatment? Did they actually progress while they were receiving their treatment drug? Or did they have to stop because it was too toxic? The drug was kind of too hard on their bodies to take. We also have to consider kind of all of the different available treatment options to that patient, including and encompassing clinical trials that may be available at either the center they're being treated or another center. And then lastly, and very importantly, we have to consider kind of the levels of evidence that are supporting whatever treatments we choose. And what I mean by that is, are we looking at data that's coming out of the gold standard in our field, which is a randomized controlled clinical trial? Or is this data that's coming out of maybe kind of registry data, just, data that's sourced from various places, or real world data, or kind of personal MD experience or patient experience? And all of those levels of data are extremely important and informative for every single person, but I will say that the gold standard, again, is that randomized controlled clinical trial whenever we're making these decisions. So right off the bat, we do kind of know, based on both retrospective data as well as randomized controlled clinical data, that PI3K inhibitors are probably not the best route to go when somebody is first relapsing. So I threw these kind of figures up here just to explain a little bit. These are called Kaplan-Meier curves, which are essentially curves that look at how a patient is doing on a particular therapy over a period of time. So if you look at the x-axis, it shows months, and on the y-axis, it really shows a percentage of patients. And what both of these are showing are what we call progression-free survival, or basically how many patients are actually not progressing on their disease, and so their disease is controlled. And so if we focus on the left curve here that I have up here, you'll see that there are two curves. That first curve, the blue one, is patients who received ibrutinib when they started relapsing, and then that orange curve, the lower curve, is the one showing patients who received idelalisib when they were progressing as their first agent. And essentially what we see here is that the curves start to, pretty rapidly start to parse out. And it shows that people who got idelalisib, which is a PI3K inhibitor, they started to progress much earlier than people who actually were put on a BTK inhibitor, ibrutinib. And now that is based on what we call real world evidence. It's kind of retrospectively going back and looking at patient data to see how people did. But we actually also on the right-hand side have a prospective randomized clinical trial, the ASCEND trial, which directly compared kind of BTK therapy with acalabrutinib versus using idelalisib with rituximab, also versus using a chemotherapy regimen with something called bendamustine. So you'll actually see three different curves there. And acalabrutinib is the highest curve on there, suggesting that patients who received that drug actually had fewer events where they progressed and their disease was controlled for a longer period of time as compared to a PI3K inhibitor or chemotherapy. And so we have this data plus other trials and kind of personal experience that suggest that PI3K inhibitors are not the first drugs that we're reaching for when somebody comes in with a relapse. So that leaves us with BTK inhibitors, and a Venetoclax strategy is kind of the two things we usually consider at first relapse. And so what are the things that we really look at to help us decide between a BTK inhibitor versus Venetoclax? And I have some of those things kind of written out there on the scales. So a BTK inhibitor, one of the benefits of it is that they're all oral drugs at this point. There's no infusions. There's no kind of concern about the tumor rapidly dying off and creating complications in the bloodstream. We don't need to admit people into the hospital who are starting a BTK inhibitor. We have a lot of long-term efficacy data on BTK inhibitors at this point. Like I mentioned, ibrutinib was FDA approved almost 10 years ago, and so we have a lot of experience with it. We have several kind of randomized controlled trials that support its use. With Venetoclax, now one of the major kind of things about it that we love for our patients is that it is a time-limited therapy. Patients do not have to be on it forever. It's only for 1 to 2 years that we actually continue patients on Venetoclax. The toxicity profile of Venetoclax is different from BTK inhibitors, so also depending on what other medical problems somebody might have, we might choose for one versus another. And if somebody is able to be retained in a remission for a long period of time, the cost may actually be ultimately better with Venetoclax, again, because it's time limited. So what are some common side effects to BTK therapy, since we're talking about kind of different reasons why we would choose one drug versus another? So very common toxicities from BTK inhibitors as a class are cardiovascular toxicities. So I have kind of two ones that we think about a lot in the clinic circled here: atrial fibrillation as well as ventricular arrhythmias, which are basically abnormal heart rhythms when patients receive these drugs. And occasionally, unfortunately, they can be fatal in people who have a very robust kind of toxicity for a BTK inhibitor. So for people who have heart disease or kind of a predisposition to having any sort of arrhythmias, we're extremely careful with prescribing those BTK inhibitors. And I will say that ibrutinib is really the drug where we have seen most of these cardiovascular or heart toxicities. Other things that we see as a class, increased risk of bleeding, high blood pressure, a lot of gut side effects. People can feel kind of like achy joints, rashes, and then of course just feeling very tired while taking the drug. Some common side effects of Venetoclax, by comparison, you don't have as many of those cardiovascular side effects, but you do have a lot of issues with potentially bringing your white blood cell count down so low that you're at increased risk of infections. And then notoriously, Venetoclax can cause a lot of kind of upset in the GI system, so people can experience abdominal pain, diarrhea, things like that. And then a huge entity that we're always watching out for is something called tumor lysis syndrome, or TLS, which is basically when people receive Venetoclax, their body can sometimes have such a robust response to the drug that the CLL cells can start to break up very rapidly and release a lot of toxins into the blood system. And that can unfortunately become a medical emergency if we're not on top of it right away. But any clinician prescribing Venetoclax is acutely aware of that TLS risk, and we monitor patients very closely for it. So as you can see, the side effect profiles of these two drugs are a little bit different. And so, all that kind of goes into the consideration of which one are we reaching for first in that patient. So there is no kind of head-to-head data right now. There is some forthcoming, but there's no head-to-head data right now of ibrutinib versus Venetoclax at first relapse. And so we kind of have to fall back on these retrospective studies, looking back at our patient experiences to see how outcomes might be affected when we reach for either one of those drugs. And so Dr. Iyer and others from the group at Sloan and elsewhere did a retrospective analysis of different targeted novel therapies in the relapse setting. And this is, again, one of those survival curves, kind of looking at how people fared if they got ibrutinib at first relapse or Venetoclax at first relapse. So it's directly comparing those two drugs. I will say one thing I'll note is that there were a lot more patients who received ibrutinib, about 382 patients versus Venetoclax recipients, which were only about 48. So even though the patient groups were pretty well balanced in terms of kind of being able to compare, two groups, the numbers were pretty different. So take all of this with a grain of salt. These findings are not necessarily what we call statistically significant, but they are, somewhat informative and interesting to see that, first of all, in this group here, this curve is showing people who had progression of their disease. So we can see that people did a little bit better with actually Venetoclax strategy in terms of their disease being controlled for a more durable, long period of time. But ultimately, this curve is actually showing survival. So how long did people actually live on the drugs? So again, most people did extremely well for the long-term follow-up. And actually, between ibrutinib and Venetoclax, it did not affect their survival in any way. So even though some people might have been progressing a little bit quicker on ibrutinib, they were still living, just as long as those on Venetoclax. And so it kind of leaves us thinking that maybe those two drug choices are equivalent in the front line, or not front line, excuse me, in the first line at relapse. So how do you choose between your different BTK inhibitors? We've been talking a lot about ibrutinib, mostly because that's the drug that we have the most experience with. But again, we have this new player on the scene, acalabrutinib, and then more other BTK inhibitors coming very soon, including zanubrutinib. And so several different things that we consider are the side effect profiles of any individual BTK inhibitor, their cost to the patients, dosing schedule. Some are twice a day, some are once a day. Of course, patient preference, and then also physician preference. Some physicians have more experience prescribing one type of drug than another. And then, of course, the levels of data and evidence that support different BTK inhibitors. Now, it wasn't until recently that we actually had some kind of good randomized clinical trial data looking at head-to-head studies of different BTK inhibitors. And so you'll see here, this is one study that's actually looking at zanubrutinib, which again should be getting approval anytime now, versus ibrutinib. The Alpine study, which was a phase 3 study, meaning that it was kind of, phase 3 studies are the latest stage clinical trial studies. And it shows that zanubrutinib actually was slightly better in terms of outcomes than ibrutinib. So on the left-hand side, we have a progression curve that shows how many people progressed when they were receiving either drug. And people actually did a little bit better with zanubrutinib as compared to ibrutinib. And then the right-hand curve is looking at how many people actually survived on the two drugs. And they're fairly equivalent, although there's a slight predisposition to doing better on zanubrutinib as well. So that outcomes data is encouraging. Interestingly enough, I would say probably the biggest kind of difference between these two drugs and why I might choose Zanu over ibrutinib in the future is their toxicity profile, the side effects that people were actually experiencing when they were receiving these drugs in the clinic. And the two biggest ones are atrial fibrillation, which again is that irregular heart rhythm that ibrutinib can actually exacerbate, especially in people with a predisposition. Those events were much fewer with zanubrutinib as compared to ibrutinib. And then similarly, kind of hypertension, you'll see that we're still kind of experiencing some of that with zanubrutinib, but a little bit better. So overall, I would say that because of kind of that improved toxicity profile over ibrutinib, I'm encouraged by these findings with this next generation BTK inhibitor. We also have another clinical trial that directly compares acalabrutinib versus ibrutinib, and the findings are essentially exactly what we already discussed with the Alpine trial. People do a little bit better in terms of their progression-free and overall survivals with acalabrutinib. Again, the overall survival is fairly equivalent in terms of how long are people living on that drug. The progression benefit is a little bit better with acalabrutinib, but really it's that toxicity profile that we're highly encouraged about in terms of people receiving acalabrutinib have fewer events of atrial fibrillation or atrial flutter, which again are arrhythmias that we really don't like to see our patients experiencing. Hypertension rates are much better with acalabrutinib as compared to ibrutinib, and much fewer people had bleeding and diarrhea, and really the biggest one that I've heard is the joint achiness. It's just a lot better with acalabrutinib. Now, of course, on the flip side of that, acalabrutinib kind of comes with its own host of kind of side effects and medical things that that we have to consider. But when you look at these toxicities of interest that we've really been struggling with to deal with people who are receiving ibrutinib, very encouraging to see that these newer generation BTK inhibitors don't have as many of these side effects, and we're still seeing really good efficacy data for them, which is wonderful. So earlier in this talk, I kind of introduced the concept of different groups of people who are coming into the clinic. People who received BTK inhibitors in the front line or Venetoclax in the front line. And then that group 3, people who received chemotherapy, which is becoming less and less, kind of moving forward. So kind of going back to that, let's think about that first group of people who received a BTK inhibitor in the front line, meaning they either got ibrutinib or acalabrutinib with or without Ven-Obinutuzumab, which is that monoclonal antibody. Keeping in mind that all BTK inhibitor options are continuous therapies. So somebody should have stayed on a BTK inhibitor until their CLL progressed, or it transformed into a different type of disease, or they were not able to tolerate it anymore because of side effects. And so what about those people who got BTK in the front line? Now, we actually have a growing list of options for how we sequence those people and what we're choosing or what we're picking up next. So we could actually go to an alternate BTK inhibitor because we have different ones available on the market right now. We could go to Venetoclax, just totally switch it up and change drug classes completely. Or we could go to a PI3K inhibitor, which we kind of already talked about. I had showed some data that really people don't do as well with the PI3K inhibitors as their first agent that we're reaching for, but obviously it's still, there as an option for somebody if for any reason we chose to go that route. So this is kind of a framework that I think of when I'm seeing somebody in clinic who's progressed after a frontline BTK inhibitor. So I really try to think about, well, are they progressing because they couldn't continue on the BTK inhibitor and now they're off of their therapy and then have progression off of therapy, something that we call intolerance, which is on that right-hand side? Or are they progressing on therapy? They're tolerating the BTK inhibitor perfectly fine, but their CLL is actually finding ways to push past that therapy and is now growing, even though that person is still taking the drug. And that's called progression on therapy on the left-hand side. And I really treat those people kind of differently in terms of what am I reaching for first. So on the left-hand side, for somebody who's actually progressing on a BTK inhibitor, I'm usually reaching for a Venetoclax strategy first because I'm concerned that they may have developed a resistant disease to that entire class of BTK inhibitors. So I would not kind of alternate that BTK. Now, for people who were actually intolerant to their therapy and had to stop their treatment because of side effects, and then they progressed when they were off of the drug, for those people, honestly, you can wait until it's time to treat. Some people with CLL don't need treatment, and we can always kind of delay that therapy until it's absolutely time to treat. And at that point, you can consider an alternate BTK inhibitor, which may have a different side effect profile and they may be able to tolerate it better and their disease might still respond. Or you can just switch up the drug class completely and go to a Venetoclax strategy. So, kind of important to think about why somebody's progressing after a BTK, because there's two different pathways that we usually consider with that. So this kind of drives home that point again, that if it's intolerant on the left-hand side, if it's intolerance, that was a reason for discontinuation, then you can reach for an alternative BTK inhibitor. If somebody is resistant to BTK and they're progressing on therapy, I usually go for a Venetoclax strategy. And then at the bottom, you'll see that there are alternative BTK inhibitors on a clinical study that actually fight against resistance mutations. And we'll talk about that a little bit later in this talk as well. Now, what these two things are kind of looking at is that these two different studies, two different curves. So on the left-hand curve, we're looking at people who received either a PI3K inhibitor or Venetoclax after they failed on ibrutinib therapy, meaning their disease progressed on ibrutinib. This is, again, a retrospective study because we don't really have that randomized clinical trial head-to-head data to help us in this particular space. But what we're seeing is that people who received Venetoclax did much better than idelalisib. And so we're still kind of looking at this PI3K inhibitor strategy as maybe not the best one to reach for when somebody has progressed on a BTK inhibitor. On the right-hand side, we're looking at two different curves of people who either relapsed or progressed because they were intolerant to a BTK or because their CLL actually progressed while they were on drugs. And you can see that people who received another BTK inhibitor, because their disease was progressing off of therapy and they were actually intolerant in the beginning, that red curve on the top, people actually still responded to an alternate BTK inhibitor pretty well. But for people whose CLL was actually progressing on a BTK inhibitor, and that's why they, have to sort of change their therapy, those people don't do as well when you try an alternate BTK inhibitor, suggesting that they might have a mutation to the entire class. All to say that we have some kind of retrospective data to support the concept that you can re-challenge somebody with a BTK inhibitor if they progressed because they had to stop due to toxicities in that front line. Now, what about Venetoclax data? So we do have some prospective data that shows that in people who are progressing in their CLL on ibrutinib or a BTK inhibitor, they actually still have fantastic responses to Venetoclax. And so all is not lost in that patient. Venetoclax is actually very active in this group of people. And this particular curve again shows kind of proportions of patients who have progression of their disease. And you can see that for a very long period of time, most people's diseases is fairly well controlled on Venetoclax after ibrutinib. And the overall response rates for those people are very high, up to 2/3 of patients, over 2/3 of patients still have excellent responses on Venetoclax. Now, what about that group 2 people who actually started with Venetoclax as their frontline treatment and never saw a BTK inhibitor? So kind of flip it around, do we have data to support that kind of opposite sequencing pattern? Now, keep in mind that people who receive Venetoclax in that frontline strategy, they were treated for a time-limited amount, 12 months, and their treatment is stopped at 12 months. People on Venetoclax do not continue beyond that first year. So what are our options kind of in this group of people? And we do have a growing list, but there's a little bit less data than in the TK inhibitor space. So kind of keeping in mind that people who receive Venetoclax in the front line receive it for a time-limited amount of time, it begs the question that if somebody has progression, say 2 years after they stopped Venetoclax, can you actually re-challenge that person with Venetoclax again? Because their disease actually responded, in the beginning, and they progressed off of therapy. So there is a question about a re-challenge of Venetoclax. Then there's the question of kind of doing those BTK inhibitors, flipping it around. So instead of ibrutinib first and then Venetoclax, doing Venetoclax and then ibrutinib. Is there data to support that? And do people respond? And then we still have that question of kind of PI3K inhibitors after then. So to try to answer the question of can we actually re-challenge with Venetoclax, the group at Memorial Sloan Kettering, led by Dr. Megan Thompson, actually performed a retrospective analysis of a group of about 25 patients from MSK and other sites, and looked to see how they fared, what were their outcomes. And essentially what the group was able to show was that Venetoclax retreatment or re-challenge can be a successful medium for a subset of patients. Essentially, 72% of patients actually ended up responding to a re-challenge. Most of those responses were partial responses. Essentially, what that means is that we were not able to completely eradicate their CLL, but we were able to get it under very good control. About half of patients kind of had that partial response. But then there were some patients, about a fifth of patients who had what we call complete responses on that re-challenge of Venetoclax, which is very encouraging. And very encouraging is that really only very few patients, actually only 6% or 1 patient from this cohort had progression after that re-challenge. And so essentially what it suggests is that re-challenging somebody with Venetoclax, if they were responding to it initially in the front line and didn't have any significant toxicities, can be a very viable solution for these patients. And I think, personally, I think it's an excellent option because it kind of keeps open other lines of therapy, BTK inhibitors, PI3K inhibitors, all of that, keeps all of that open to people. You kind of have it in your back pocket. even as you're attempting a re-challenge of Venetoclax. Now, this was another retrospective analysis kind of performed by the group over at Memorial Sloan Kettering, led by Dr. Mato, Anthony Mato, which looked at other sorts of therapies after Venetoclax discontinuation. So this particular curve is looking at BTK inhibitor patients. So people who never ever saw a BTK inhibitor, got Venetoclax in the front line, and then received a BTK inhibitor when they progressed. And what we see is that there was an excellent overall response rate, meaning that 84% of patients actually had an excellent response to a BTK inhibitor. And people did not progress for a very long period of time. The median progression-free survival, meaning by the time that half of patients progressed, was around 32 months. So that response was very durable and held for a long period of time. So there is data to support the use of a BTK inhibitor after Venetoclax. The depth of that response and the success of that response to a BTK inhibitor really depended on why somebody might have discontinued the BTK inhibitor if they were exposed to it before. So kind of just to clarify, going back, this curve is looking at people who never received BTK inhibitors, but then for people who may have received a BTK inhibitor or been exposed to it in the past and then got Venetoclax, and then we're looking at, can we re-challenge them with a BTK inhibitor? People, again, the same story as we've kind of shown before, people who were intolerant to a BTK inhibitor, and that's why they had to stop, they actually had excellent responses with an alternative BTK inhibitor. But for people who actually progressed on a BTK inhibitor, re-challenging them with an alternate one did not lead to excellent kind of progression-free survivals. And so, again, very important to think about why somebody progressed on their prior BTK therapy, and it helps inform us make that next decision for their therapy. And then lastly, PI3K inhibitors did not really result in durable remissions in people who had received Venetoclax and a BTK inhibitor. And so, it kind of begs the question of is there really still any role for PI3K inhibitors here in the treatment of CLL, just kind of given the fact that we have many other targeted agents that are coming down the pipeline and available to our patients. And then kind of over and over again in retrospective analyses and in prospective trials, we've seen that durable remissions are not really obtained by this class of drugs. But again, it's still available to the patient who may be, there are still some people who do respond to PI3K inhibitors, but definitely not kind of the first drug that I'm reaching for off the shelf. And so beyond kind of our current understanding, beyond those sequences that we have right now, what else is coming down the pipeline and what do we have next? I've already kind of brought up a couple different points about that throughout the talk, so we're going to expand on some of those areas for the rest of this talk. And so I wanted to first kind of introduce the concept of the double exposed patient, which really represents an unmet need in CLL in terms of what is our optimal therapy for those patients. And what I mean by the double exposed patient is the person who is exposed to both Venetoclax and a BTK inhibitor. And then what are we kind of reaching for in the third line? And so current standard of care options, we still have chemotherapy available to us in our back pocket if we need to use them. We've talked about PI3K inhibitors as another potential strategy, but really for this double refractory patient who, we've tried alternate BTK inhibitors, we've tried different Venetoclax strategies and they're still not responding. My personal preference is to go to clinical trial options for those patients. And I think personally, I do think it is the best way to treat, this group of people with highly refractory disease. And current clinical trials that I'm very excited about in the field of CLL is looking at a whole new category of BTK inhibitors called non-covalent BTK inhibitors, which will introduce that concept in the next couple slides. CAR T-cell therapy, which we'll talk about more as well. Stem cell transplantation is currently under investigation for CLL. And then several other investigational agents, which may be available in clinical trials across the country. And and really that is what I would go for in the double refractory patient. I will also mention that in our standard of care options, the landmark clinical trials that actually led to approval of PI3K inhibitors and chemoimmunotherapy combinations and all of that did not include patients who were previously treated with BTK inhibitors or Venetoclax. And so we're really having to extrapolate to this patient population to know how will they respond when they've already been exposed to those agents in the front line and then in the first relapse setting. And so kind of building on that framework, talking about some of those clinical trial options, well, let me actually go through a little bit more. So this slide is really here to kind of summarize what I just mentioned about that double refractory patient. So you have people who receive a BTK inhibitor, receive Venetoclax, or receive a combination of the BTK inhibitor and Venetoclax both, and they've progressed on their disease. We have that double refractory CLL patient. And so I think the most important thing to understand for that person who's having a progressive CLL on all our available therapies is why are they progressing on treatment? And for a long time, we didn't actually really understand kind of why somebody would progress, but recently there's been a lot of breakthroughs in understanding the actual biology that causes somebody to be resistant to a BTK inhibitor. The major resistance mutation that we have now found is something called a CYS481 mutation, or BTKC481, which I have written down there in the slide. And essentially what this graphic is also showing is that in the signaling pathway for CLL, there is an essential protein called BTK, which is what we target with the BTK inhibitor. And that BTK protein can become mutated to the point where a BTK inhibitor drug like ibrutinib can't actually bind to the BTK drug protein. And the CLL cell finds a way to bypass that drug and continue to grow and proliferate, even though we're trying to block it with a BTK inhibitor. Another mutation that's kind of probably the second most common mutation that we've seen in resistant disease is a mutation in a protein called PLCG2, which is a little bit downstream of BTK. And so I would say that probably about 2/3 of patients who are resistant to a BTK inhibitor have a mutation in the BTK protein itself. And then approximately 70 to 80% of patients in total have either resistance to the BTK protein or to this PLCG2. And then there are still other kind of smaller cohorts of people who have other mutations that we are kind of still discovering and have yet to know exactly what resistance mutations are out there. And so when somebody develops a mutation like this, what can you do to treat that person's disease? So several next generation BTK inhibitors are currently in the pipeline being developed to try to address this question completely. And the one that I have circled, LOXO305, is the one that has kind of progressed the most in current clinical trials, and is one of the ones that I'm very excited about coming to clinic, hopefully in the next couple of years. So LOXO305, also known as pirtobrutinib, essentially has a different binding pocket to the BTK protein, where it does not permanently bind to the BTK protein. It actually kind of just sets up shop inside that protein, but it's not totally linked or bound to it. That actually is a huge deal, because even if the BTK protein is slightly mutated, LOXO305 is still able to get in there and block that protein. And so where ibrutinib may fail because it can't actually bind the BTK protein, LOXO305 is able to overcome that resistance mutation and still be highly effective in our patients with CLL. And so This is some early phase data by Dr. Mato and others in the group that is looking at progression-free survival in patients who received pirtobrutinib or LOXO 305. And both of these curves are looking at what we call progression-free survival. One on the left is looking at people who received a prior BTK, and the one on the right is looking at that double refractory patient who received both a prior BTK and a BCL2. And you can see that the progression curves are actually really excellent in terms of their durable kind of remissions and responses, and approximately 74% of people remain on pirtobrutinib even if they received BTK in the past and had an identifiable resistance mutation. So, highly encouraging data, and suggests that we may have found a way to crack the code in terms of being able to circumvent these resistance mutations and still treat these people with a BTK inhibitor. Another category that I kind of briefly mentioned is CAR T. So CAR T, for those who aren't familiar, it's a type of what we call immunotherapy. It's essentially taking a type of white blood cell called a T cell from a patient's blood and then reverse engineering that T cell by interjecting something called a CAR, or a chimeric antigen receptor. I know this is like a lot of voodoo science, but you basically take that gene, insert it into the patient's T cell, grow millions of the T cells that are then expressing that gene, and infuse the T cells back into people. That CAR that's been inserted into the T cell, what it does is it actually teaches the T cells to fight the patient's cancer specifically. It's really an ingenious way to harness somebody's own immune system using their own T cells to fight back at a cancer, and has been a highly effective strategy for many people, albeit has not really kind of been FDA approved for CLL, but is still under investigation. And so one study that I'm pretty excited about in terms of responses that are coming out soon, something called the TRANSCEND trial, which is looking at specifically the use of CAR T in CLL. And this is just kind of going through the way the trial was designed. Basically, there's a group of people who got just the CAR T, something called liso-cel, and then there's a group of people who are getting liso-cel with ibrutinib therapy. And investigators are mostly interested in looking at kind of the safety and response data for these people. And what we see is that over a period of about 2 years, people had excellent responses on CAR T therapy. The red is people who had complete responses, and then the blue is people who had partial responses. And so you'll see the vast majority of people were actually able to obtain either a complete response or a partial response. And these three bars are really looking at first the total group of people, which was 22 people, and then the people who got one dose level of the CAR T, and then the last group of people who got a higher dose level of CAR T. Now, albeit it's only about 22 patients at this point, so it's very, very few numbers of patients, and we're going to have to extrapolate a lot from this to be able to bring this, feasibly into the clinic for our patients, but still very encouraging data, especially for that double refractory patient. Allogeneic stem cell transplantation does still remain an option for people with CLL. It's not usually the first or the third or even the fourth kind of treatment line that I'm reaching for, but it is absolutely there. And we know that it can be an effective strategy for some. And this particular analysis is looking at the use of allogeneic transplant and outcomes for people who actually receive novel agents in the front line. All of our kind of clinical trial experience with stem cell transplantation in CLL has been based on people who didn't receive novel agents. And so it's a little bit of a data-free zone, but this retrospective study does support that patients still have excellent kind of progression-free survival or overall survival from even if they receive novel agents in the front line of the and in relapse. And so that is encouraging as well as a potential treatment option. And so if I were to summarize kind of all of it together, I know that was a lot of information and talking about a lot of different drugs. In the modern era, kind of using a non-chemotherapy-based treatment strategy for CLL in the relapse setting, we think about kind of two groups of people who received Venetoclax in the front line or people who received a BTK inhibitor in the front line. So going through that Venetoclax strategy, people who first received Ven really have to think about, did they progress while they were getting their therapy? Did they progress after they completed their 12 months of therapy, or were they intolerant to Venetoclax and that's why they had to stop? For people who progressed on Venetoclax, I would just go ahead and get a BTK inhibitor because they've obviously kind of failed BCL2 inhibition and maybe resistant to trying Venetoclax re-challenge again. For people who had an excellent response to Venetoclax but then progressed after the therapy had already completed, then those people can potentially be safely re-challenged with Venetoclax before reaching for another alternate BTK inhibitor. Or you could just go to a BTK inhibitor and then keep Venetoclax kind of further on down the line in your strategy as a re-challenge if needed. For people who were intolerant to Venetoclax, you could always challenge them again, but change the dosing of Venetoclax to maybe try to reduce that dose and make it more tolerant while still eliciting a response from those people. Or you could just go to a BTK inhibitor. Now, when those options have been exhausted and you have somebody who's progressed, even on their alternate options, you can consider a clinical trial. And really, I would be reaching for potentially a non-covalent or alternate BTK inhibitor trial or a cellular therapy trial. Now, moving to the right side of this graph, for somebody who got a BTK inhibitor in the front line, you really have to think about, were they progressing while they were receiving therapy, or were they intolerant to their BTK inhibitor and then progressed after being taken off the drug? For people who are progressing on a BTK, the concern there is that they may have a resistance mutation, and so they would probably not respond as a class to BTK inhibitors, and I would instead reach for Venetoclax with a monoclonal antibody. But if somebody had to stop a BTK because they were intolerant or had side effects, and I'm thinking about potentially re-challenging them with a BTK, for those people, trying an alternative BTK for a different side effect profile, or potentially, it's not on here, but potentially trying a reduced dose of the same BTK inhibitor is a viable treatment option, or just switching it up completely and doing the alternative drug class and going with the Venetoclax route. And again, for those people, kind of all roads lead to considering a clinical trial or a cellular therapy, and kind of all the way to the backside, potentially a PI3K inhibitor for people who are double refractory and not responding to our other options. So hopefully that gives a good framework to kind of think about relapsed CLL. And I just want to say thank you so much for coming to this talk, and thank you to the Lymphoma Research Foundation for the opportunity to give this talk, and to Memorial Sloan Kettering Cancer Center, where I currently work. So